Alrighty, everyone. Good evening. Looks like we're coming on live to YouTube. Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractic physician at Gates Brain Health. And tonight I'm talking about Alzheimer's and are there early preventative strategies that we can utilize for this condition. So let me exit out of here and I'm going to present from the beginning. Okay, so in order to understand maybe some preventative strategies, we first have to understand really what Alzheimer's is, how it's different from other conditions, and hopefully throughout this broadcast you'll understand that. Most of you are probably watching this broadcast because you are scared or concerned about developing Alzheimer's. Anyone who knows someone with Alzheimer's, you realize what a destructive condition it is, how emotionally painful it is, oftentimes for the family, and it's an existence we don't want for anyone, so to speak, as they live with this condition, because as some neurologists refer to it, as I mentioned in the prelude, that it's really a failure of the brain, and again, it's something that we want to prevent if we can. Am I saying that we have a 100% preventative strategy? No, but I'll give you the research up to date and what a lot of people are talking about in terms of things that maybe we can do in order to help our brain to be as healthy as long as possible. So Alzheimer's disease is a decline in memory, cognitive function, language, problem-solving, focus, arithmetic abilities tend to decline. We can have behavioral and personality changes. And Alzheimer's is actually the 6th leading cause of death, which is actually pretty surprising. It's pretty high, so to speak. So, and it's only going to become more common, as I'll discuss later on. So the decline in declarative memory is really the main feature of Alzheimer's, differentiating it from other forms of dementia, which I'll get into. And then again, language can be affected, problem solving, attention is affected, and then the ability to, compute numbers, that tends to go south, which is why doctors in the standard battery of memory tests are going to ask individuals, to subtract 7 from 100, and they're going to give them working memory tests. Remember these 3 nouns, and ask the person what were those 3 nouns after 3 minutes. So those are the features of it. Who coined the term? I believe his name was Apoe Alzheimer's, and he coined the term in 1901. Again, Alzheimer's is a type of dementia. That's kind of a confusing distinction for a lot of people. So there are many different types of dementia, but Alzheimer's is the most common form of dementia. Other forms include vascular dementia, Parkinson's disease and the Parkinson's plus syndromes, alcohol, you may have heard of it as Wernicke-Korsakoff syndrome. AIDS and syphilis can cause dementia, tumors, thyroid disorders, and metabolic syndromes. Not metabolic syndrome, but different types of metabolic syndrome, so to speak, can cause dementia. Okay, so this picture is from the Principles of Neuroscience, and it's illustrating how we're living longer. So prior to the 19th century, the human lifespan was around 50 years, whereas now the lifespan is just growing and growing and growing in terms of decades. And so we're living longer, and because we're living longer, we're seeing age-related diseases amplify. Alzheimer's is a perfect example of that. Alzheimer's has a female preponderance, so 2 out of 3 Alzheimer's patients are females. The economic impact is astounding. So they're now saying that they anticipate it to be around $2 trillion a year is going to be dedicated to Alzheimer's disease, I believe, in the next 10 to 20 years. We have neuritic plaques, beta amyloid plaques, and neurofibrillary tangles, which are the hallmark of the condition. So what does that mean? I attached a slide. Again, this is from Principles of Neuroscience. and it's really the foremost textbook, so to speak. Excuse me, it's late, but it's the foremost textbook on neuroscience, basically, that we have in contemporary society. So it's a great book, and in this chapter, they demonstrate some key features of Alzheimer's. So this is a neuron, and within the neuron, we have these tangles, so to speak. You can assume that these tangles are not good. And then out here we have the beta amyloid plaques that you may have heard of. The beta amyloid plaques are made of beta amyloid. Beta amyloid is let me say it this way, amyloid is a normal protein within our body, but this misfolding of the beta amyloid into these plaques becomes pathological. These tangles are made up of tau. You may have heard of phosphorylated tau when I talked about chronic traumatic encephalopathy. So this hyperphosphorylated tau forms the neurofibrillary tangles. And then if you look at this is a section of the brain, and here they're identifying the tangles, and then here you can see the plaques. So this is the histological lesion of Alzheimer's disease. And then I had some true or false questions. Muscle loss and aging has nothing to do with the nervous system. That is false. Basically, they find that we tend to start losing muscle tissue because we can lose like 25% of our motor neurons, so to speak, as we age. The aging brain shrinks because neurons are lost. That is actually false. So the aging brain actually shrinks because we're losing connections between the neurons in the brain. We're not as much losing the neurons themselves in the brain. So it's kind of interesting. So you may lose muscle because you're losing motor neurons, but you're not losing brain tissue because you're losing brain cells. You're losing brain tissue primarily because of the connections withering. And then what are the characteristic features of Alzheimer's? I think we already talked about that. Again, declarative memory loss is the main thing that is going to occur, and that's what families notice. You say something to someone, and then you ask them 3 minutes later, what the answer is, and they don't even remember you asking the question, so to speak. So declarative memory going down is the main feature, and then we have behavioral issues and language issues and problem-solving issues that come with it. Just for you to have a frame of reference, this is what the normal brain looks like. These are the ventricles. You can see them here. Whereas in Alzheimer's disease brain, we can see that the gyri, the cortical gyri, they're not as dense. We see that the sulcal depths, so to speak, are increased. And then we can see the ventricles are rather enlarged in an Alzheimer's patient as compared to someone who's normal. The ventricles become enlarged because we are losing these connections again in the brain. And with Alzheimer's, that pathology, you can have neuronal death, to my knowledge. So basically here, I wanted to give you a comparison between chronic traumatic encephalopathy and Alzheimer's. I think it's important because, as I mentioned, you have these neurofibrillary tangles, which are hyperphosphorylated tau, basically. And tau, or a tauopathy, is central to chronic traumatic encephalopathy. CTE is being seen in a lot of the head impact sports athletes, boxers, football players, rugby players. And one of the key questions early on with those individuals was, how is their brain different? They're displaying some signs of Alzheimer's, but displaying a lot of signs of behavioral problems, depression, more than per se declarative memory issues. And so the neuropathological lesion is a little bit different. So I attached this article, and this is from Dr. Anne McKee's work. She's like the person that carried the ball and ran with it after Dr. Omalu discovered chronic traumatic encephalopathy. And you can see that the lesions start in CTE more towards the surface of the brain, whereas in Alzheimer's, it's going to start deep down in the brain. And then as it progresses, we have multiple centers, frontal, temporal, parietal cortices, so many different areas, whereas in Alzheimer's, more towards the second stages, you're seeing it more in the area of your brain where you smell, the transentorhinal cortex and entorhinal cortex. As it progresses, CTE as it progresses, you can see it's widespread. Many areas of the brain, including the hippocampus, that's your memory area, the amygdala, that's your fear area, basal ganglia, that's your deep control nuclei for motor movements, eye movements, thoughts, emotions. Whereas Alzheimer's is now more in the hippocampus, amygdala, basal temporal cortex. Your temporal lobe is largely associated with memory. That's where your hippocampus is located. And then you can see late in the stage of chronic traumatic encephalopathy, it's pretty much throughout the whole brain, and it particularly involves the cerebellum, that's your balance center. Whereas Alzheimer's disease can involve all areas of the brain, but not the cerebellum. So these are ways that neuropathologists can distinguish between, let's say, someone who has played contact sports versus someone who has Alzheimer's disease. And then these are more, you can pause this and go back and read this, but this is just a fantastic comparison again of some of the neuropathological findings. Here you can see the hyperphosphorylated tau and the sulcal depths, but you don't see that as much in Alzheimer's disease. Alzheimer's affects the deeper cortical layers. Chronic traumatic encephalopathy affects the superficial cortical layers, which is what we'd expect if we were banging our head against other people for long periods of time playing something like boxing or rugby or football. And here you see the beta amyloid plaques. You're not seeing that as much in chronic traumatic encephalopathy. So I attached this article because I thought it was nice how they labeled the other risk factors that may be associated with the development of Alzheimer's include severe head trauma, low levels of education, female gender, previous depression, and vascular factors. And depression is a question I get a lot regarding the probability of developing Alzheimer's. And there does seem to be a link. Do we understand exactly why it's occurring? The answer is no. But there are some smoking guns, so to speak. So depression, the cornerstone physiologic component of depression, is that the fear center enlarges and the memory area shrinks. And when that happens, we lead to excessive activation of the stress hormone cascade, which feeds back to the brain and further shrinks the memory area. And as a result, that allows the fear center to further enlarge. So that atrophy of the memory area is thought to maybe predispose some people with depression who have other genetic and environmental factors that can come into play to allow them to develop Alzheimer's disease. Researchers are not really sure if it's one specific type of major depressive disorder or one type of physiologic component of major depressive disorder that then allows them to become Alzheimer's patients, or again, if it's what I said before, it's just this confluence of risk factors coming together along with depression. But depression certainly is a condition of the memory area, and even brain-derived neurotrophic factor, BDNF, tends to be reduced in depression, and when that's reduced, we have decreased ability for neurogenesis in the hippocampus, the memory area. So this was an interesting article from Frontiers in Neuroendocrinology, and I put this article here just to illustrate how chronic stress does affect that hippocampus, the hippocampal volume loss, decreased neurogenesis seen with depression. Now this is a great diagram, again from Principles in Neuroscience, illustrating the complexity of Alzheimer's. And here you can see that toxins may contribute, viruses may contribute, prions, these are these proteinaceous infectious particles, they may contribute. Head trauma, as I mentioned, low level of education may contribute. And then here they talk about genes. So the amyloid precursor protein is on chromosome 21. What we know is that individuals with Down syndrome, they have trisomy, so to speak, of the 21st chromosome. So they have 3 copies of this 21st chromosome. And after the age of 40, they invariably develop dementia. They develop an Alzheimer's-like clinical syndrome. And it's thought that because they have so much amyloid precursor protein, which turns into amyloid protein, that somehow predisposes them. there's also these PS1 and PS2 genes, which stand for presenilin, and those involve how the amyloid protein is basically cut up, which we're finding is really important for the development of the beta amyloid plaques. As I mentioned, Down syndrome, other genes, which definitely includes the Apoe gene, which I'm going to talk about in a little bit. Okay. And I think I'll talk about the Apoe gene right now. And I'm going to have kind of a recommendation list for all of you who are concerned. The Apoe gene is something that can be tested. Those who have the Apoe4 gene, and there's an Apoe2 and Apoe3, the Apoe4 seems to increase one's risk of developing Alzheimer's by like 4-fold. So if you have a family history of Alzheimer's disease, if you have a first-degree relative with Alzheimer's, if it was me, I would really want to be checked for my Apoe status. Just because it's going to tell you the probability then potentially of developing Alzheimer's, and maybe that can be something that incentivizes a person to do as much as they can. You know, we don't know if that's going to be all for naught or if that is going to yield some result, but it may be the incentive to try and do everything we can to improve brain health. And so Apoe4 status is really important. So as we look at this, when we look at these genetic causes, they're actually relatively rare in the grand scheme, so to speak, of causing Alzheimer's. So these presenilin 1 and presenilin 2 genes are really important for those who develop Alzheimer's before the age of 60. So the early onset Alzheimer's patients tend to have a really strong genetic component. It can be an autosomal dominant component to their illness, but the vast majority of Alzheimer's patients are going to develop it in a sporadic fashion more when they go into their 70s and particularly their 80s. And it seems that this Apoe4 status is super important for that, as well as other environmental factors, which we're now going to talk about. Is Alzheimer's disease a type 3 diabetes, a critical appraisal? So in this journal, they really gave a nice layout about this relationship. And it seems that Alzheimer's disease is associated with conditions of insulin dysfunction, particularly insulin resistance and or frank diabetes. And what the research seems to be coming to the conclusion is that when we have dysregulated blood sugar, we get this excessive activation of this enzyme called glycogen synthase kinase 3 beta. And when that is activated, it leads to beta amyloid plaquing as well as these neurofibrillary tangles because of hyperphosphorylation of tau. Somehow that is happening. And there's a lot of debate in the literature right now if it's due to too little insulin, too much insulin. Maybe it is more related to these GLP-1 agonists. So GLP-1 basically stimulates your pancreas to produce insulin, but it also has effects on insulin resistance. So there's all these nuances that in essence are being investigated. A lot of the research is being done on mice right now, and there seems to be a debate, so to speak, in the literature whether it's too little insulin or too much insulin, but just no dysregulation of insulin seems to be the problem. And so tight control of one's blood sugar seems to be important. Also, in the Principles of Neuroscience chapter that I've been showing you, they said the one conclusion is that caloric restriction seems to be the most helpful therapeutic, so to speak, for Alzheimer's disease or potentially preventing Alzheimer's disease. So caloric restriction is really important because the higher calorie diets we eat in these Western societies, the more GSK3 activation we seem to have. And the more of that we have, then the more misfolding of amyloid protein we have, and the more phosphorylation of tau we have, increasing our risk of Alzheimer's disease. And if you couple all of that with an Apoe4 status, or something like a history of head trauma, or poor education, or not you know what I mean? That's how it's labeled in the literature. So not a lot of education earlier in life. Those can be factors that then lead to one developing Alzheimer's. Okay. So what can you do? So sirtuins and resveratrol have gained a lot of attention. So for all of you wine drinkers, red wine contains high doses of resveratrol. I think I remember going back to the 90s, there was a 60-minute special on how the French were so healthy, and was it because they take a 2-hour lunch, or was it because they have 2 glasses of red wine with their lunch? I think the conclusion was that it was the red wine. So red wine does have benefits, and so red wine is rich in resveratrol and sirtuins. If you do not drink, you can take resveratrol via a supplement, and some of the foremost researchers on aging, which is now a whole field to itself. You can look them up on YouTube, but basically they talk about how they take resveratrol every day, and they do fasting protocols, and I think they take a few other supplements. But resveratrol and fasting are kind of the 2 critical building blocks that they seem to work off of. So fasting, caloric restriction is really important. Why? Because with fasting, we can really regulate our insulin and our insulin sensitivity. We are in just an insulin dominant world. When you study biochemistry, you'll learn about the well-fed state versus the fasting state. And really, humans are meant to be in both of those states at different times, whereas in contemporary society, we're more just in this well-fed state. And so we're producing insulin. We're eating all the time. We're eating high-calorie foods, high-calorie drinks, high-sugar drinks, leading to a lot of insulin production. This is really the concern amongst the Alzheimer's research groups of what's going to happen, because 10% of the population is diabetic, at least a third, about 33% is pre-diabetic. Those numbers are growing, and what is that going to do to our aging population, who's now living longer because we're able to keep them alive longer with different strategies, from antibiotics to vaccinations to cleanliness to life-saving, heart procedures. So now we have individuals living longer than maybe they would have, and they're more metabolically unhealthy, which is going to lead to their brain being more metabolically unhealthy. Learning new skills is important. So learning to play the piano, for example, that's been talked about a lot. Getting your ApoE4 status checked is really important. On this list, I really should have having your insulin sensitivity checked, which there are blood tests that can look at your blood sugar function, how you respond to sugar loads, how resistant to insulin you are, and then getting a volumetric MRI. This is a scary feature for a lot of people because they may not want to know, and I completely understand that. I've been doing volumetric MRIs on patients for at least the last couple of years now, and it took me a while to do one on myself. So I understand that trepidation, but getting a volumetric MRI can tell you where you're at relative to age-matched controls in terms of the density of your temporal lobe, the density of your hippocampus, the density of your frontal lobes. So the size of your ventricles. So that can be a predictive status, so to speak, of who is going to develop potentially Alzheimer's. So that is what we know at this point in time. You can see that a lot of the recommendations in these medical journals and premier neuroscience textbooks or neuroscience textbooks relate to largely what we're eating and what we're doing in terms of lifestyle, not as much relative to medications. There's a whole Pandora's box of medications being explored right now, of immune therapies, antibodies that may chew up the beta amyloid plaques and things like that, but nothing has really come out that is uber definitively curing Alzheimer's disease. So, and there are other medications that improve acetylcholine in the brain or acetylcholine between synapses. I won't go into those. You're probably aware of those. But basically, if you're concerned about having Alzheimer's, concerned about developing Alzheimer's, this is what I would be paying attention to. So if you have any questions, let me know. Thanks for hanging with me during this broadcast. It's late, and it's almost 11:30 here. I wanted to get this broadcast done today so you all could have it, and I think that's it. So thanks for watching, and I will talk to you later.